All right. So who wants to go first? Let's look at this question right here. This is an important question that has a lot of good details. It has a good list of differentials. A list like this, we could explain it properly. We'll understand a lot. So can anybody participate? Let's see. Is anybody willing
Uh,
to part? All right, you want to
yeah, can I?
participate? Perfect.
Yeah,
All
can
right.
I do it?
Yes.
Okay. So, which of the following additional findings are most likely to be seen on autopsy? A 35-year-old woman is evaluated for a 3-month history of appetite loss, fatigue, weight loss, and abdominal pain. She has no chronic medical conditions and takes no medications. While undergoing upper GI endoscopy, the patient develops cardiovascular collapse and dies, despite aggressive resuscitative measures. On autopsy, increased pigmentation is noted around the nipple, areola, and anal and vaginal mucous membrane. Which of the following additional findings are most likely to be seen on autopsy?
Okay,
Okay.
so which of the following additional findings are most likely to be seen on autopsy? So they kind of want you to diagnose it first and then include one of the features that's on this list.
Okay.
So, yeah, what do you think the
So,
diagnosis is?
I'm suspecting that it might be the Addison's disease
Okay.
because upon going upper GI, like the invasive procedure, she collapsed, and which tells me that the cortisol, the stress hormone, wasn't there to increase her blood pressure. And the other thing is the increased pigmentation, which shows me that the problem it lies in the adrenal glands because adrenal glands were not working, so therefore the anterior pituitary was stimulated to release ACTH and the POCN, like
Okay. That
pro-opioid.
that makes sense. That's a good clue right there because with that clue, you're able to see hyperpigmentation, right? Increased hyperpigmentation. That kind of explains why.
Yeah,
So this is a huge clue here.
yeah. So
Hyperpigmentation.
for what I know of that the pigmentation is generalized, but reading this vignette, I'm not sure. It might be around the specific areas as well.
Okay. Well, let me tell you. Typically, when we have hyperpigmentation, the areas that are more exposed to hyperpigmentation happens to be the folds, like the crease that we have. Like you can see my hand, how it has these crease formed. These areas here are going to get more pigmentation. These areas are more, um, let's say, susceptible to have pigmentation in that realm. And they're also saying around the nipple, areola area, anal, vaginal mucous membranes as well. That's the most notable. That's where they'll be most notable. There, your skin is thinner, so the skin will express a darker color. You can see it a lot easier, right? That makes sense.
Yeah.
So, yeah, what do you think the answer would be here in a question like this?
So I'm confused between A and B, but I think it might be A because the most common cause of the Addison's disease is the autoimmune destruction of the
Oh,
adrenal gland. I,
perfect. That is
okay.
that is that is true. But now there's a clue here that lets you differentiate these two immediately.
Yeah, because for the adrenal hemorrhaging, I remember the Waterhouse Fredrickson syndrome, where I think we need to have meningococemia, like the infection. So there's no infection in the history, so that's why I will go with A.
Okay, A, atrophy of the adrenal glands. Now I'm going to tell you, watch out with B, because B, there could also be other types of issues that can cause adrenal hemorrhage. It won't only be because of Neisseria. You're
Okay.
also going to see that when tuberculosis, so let's say a patient has TB, when it reactivates, remember it can reactivate, then cause issues, let's say in the superior pole of the lungs, you'll see that it will destroy the tissue and it will reach the vessels. It'll reach the actual vessels, the circulation. And when it has access to the circulation, it can then travel in the blood. We call that bacteremia. And when TB is now circulating, it can make contact with the supraadrenal gland as well. So TB and Neisseria both are types of bacteria that can affect damage at the supraadrenal gland. Remember that. But yes, typically that's what we see. And now, one big clue that would tell me right away that B can never be the answer here is that it says 3-month history of appetite loss, fatigue, weight loss, abdominal pain.
Oh, yes. Yes.
Yeah. So put that into your mind whenever you want to actually differentiate. A good technique, a good ability to differentiate the diagnosis pretty well is going to be onset. Onset. Because if it's something gradual versus something that's acute, that will basically let you know about two different types of disorders, two different types of diseases, or two different types of pathophysiology. For example, in strokes, you can have an ischemic stroke that traveled, a little clot that made its way through the circulatory system and was able to clog some type of vessel, impeding the irrigation to a specific type of tissue. You can see something like this that happens immediately, right? Or we can see some kind of atherosclerosis buildup that with time, little by little, you're seeing that the tissue is receiving less and less irrigation until the irrigation is minimized so much that you start to have symptoms, greater symptoms. So this is more gradual, while this is more acute. And it's like this with many different types of disorders. You see this in situations where patients can have, let's say, angina, where they can have a stable angina and then it turns unstable, versus a patient who is taking cocaine and has a coronary vessel spasm all of a sudden. And all of a sudden, out of nowhere, without having a history of angina, the patient will have an increase in troponin and ST elevations. So the onset of a disease is always a good way to try to differentiate because it leads to two different types of pathophysiology. So that's something that you can utilize when you want to differentiate. When you're stuck between two answers, you can say, okay, yeah, so I'm thinking about this. I should make a list, like a check-off list, because a lot of people can eliminate choices. They eliminate choices very well. And then they get up to a point where it's like 3 different choices or 2 different choices. And it's like, wow, how can I get this diagnosis? There should be like a check-off list, just in case anybody falls into this scenario. You can say, okay, what's the onset? That's one thing. Another thing is medication. Is he on a medication that's related to the pathological situation that's being presented? Is it a side effect of the medication? Is he not responding to the medication? So there's a whole approach when you want to rule out. So, and if nothing works, go with the bottom answer, right? If nothing works, yeah, go with the bottom answer. If nothing is working in that list. But yeah. Okay, so yeah, you were gonna say something. What were you gonna say?
No, I don't remember.
Yeah, I talk over people. I'm sorry. Then they don't remember.
No,
It's
okay.
common.
But
It's
I guess it was nothing important.
okay.
Yeah.
Okay. Well, another thing that was huge is that this patient had a cardiovascular collapse and dies. She dies.
Yeah, exactly. It gave it away.
Yes, that's always going to be a huge type of problem. There, the patients are dying. Remember that this cortisol is something that's life or death. Cortisol. You need cortisol. Remember how cortisol works at the level of the vessels. It has a permissiveness effect, increasing the sensitivity of alpha 1 receptors. And these alpha 1 receptors, remember that norepinephrine has more affinity to alpha 1 than epinephrine. Epinephrine kind of looks like a B. So I can say this has more affinity to betas. The only rule is that all catecholamines, when they're at higher levels, dopamine, norepinephrine, epinephrine, if it's a catecholamine, the rule is at high dosages, it'll always try to bind alpha 1. Well, norepinephrine always tries to bind alpha 1, but that's just the rule there. All right. So let's differentiate. Let's break this question down 100%, because typically they gave you some symptoms here. They said appetite loss, fatigue, weight loss. So something that is huge, you're going to see are red flag symptoms. We mentioned them before. And if I ever see a patient undergoing weight loss, I'm concerned. Concerned, typically, this is one of the red flag symptoms that you are supposed to be alerted. You're supposed to think, okay, this might be cancer. Always, if you see some kind of unregulated kind of weight loss, cancer should kind of go into your mind, but just letting you know, red flag. Red flag is also having to do things like melena or any kind of blood in the feces. Any kind of bleeding like that as well as a red flag symptom. An adult who's over the age of 50, who's presenting with these kind of fatigue and weight loss and all that, that's also a red flag. So be aware of red flag symptoms. That's another thing. But let's see. What else can I say here? Increase pigmentation. Yes. Yes. We spoke about this before. We mentioned the whole idea of CRH. CRH making its way into the body and causing this reaction. We said that that's part of the hypothalamic pituitary adrenal axis. So this is an image here of CRH from the paraventricular hypothalamic nucleus, definitely getting releasing ACTH. And ACTH is super important because of what we talked about yesterday. Just to recap, we mentioned that ACTH comes from POMC. We spoke about this. We said that there are endorphins. There are going to be ACTH, which is super important, and MSH. So this has to break down. This breaks down into these type of peptides. These are peptide hormones. Remember, peptide hormones means that they're protein. So they have to bind to a receptor outside of a cell. They're binding receptors. Okay, they're binding receptors outside of a cell. Okay, good. And what else? So yeah, we did mention bilateral adrenal hemorrhage, and yes, Waterhouse-Friderichsen syndrome is what can be seen in that sense with Neisseria. That's one thing that's very huge. But just remember one thing: it is going to be acute, definitely acute. It's going to be a cause here of primary adrenal insufficiency, and it's associated with septicemia. So in this case, the bacteria has gained access to the blood system. We call that bacteremia. But when it activates, when it does an immunogenic response, when our immune system reacts to it, now we have septicemia. So you're going to have these kind of complications. It's associated with DIC, as you can see, and the endotoxic shock. So remember endotoxic shock. Typically, remember that there's something called toll-like receptors. I'm always reminding people about the toll-like receptors and the activity of PAMP. These two things. Remember the classic type of PAMP, the classic type is LPS, lipoprotein. So it's a lipoprotein polysaccharide. Lipopolysaccharide. I'm putting the lipid A into it. That's what's my problem. Lipid A. This is the classic type. This is usually found on gram negative. But in Neisseria is special. It has LOS. It has LOS instead of LPS. That's a special feature there. You don't see that with the other types of bacteria. That's what makes Neisseria kind of exclusive in that sense. Okay, keep that in mind. It has a weird PAMP. The way it reacts, this pathogen-associated molecular protein is kind of different. Okay, keep that in mind. All right, so if we look at this, what else was in the answer choices? Let's explain all the answer choices and then move on to the next one. Ischemic anterior pituitary necrosis. What is that? What do we know that to be? Can anybody tell me? What happens when you have ischemia? The anterior pituitary necrosis. Ischemic, this is typically, everybody knows this. This is Sheehan's, right? This is going to be Sheehan syndrome. This is Gihan syndrome. And then you have the pituitary apoplexy. This is basically an infarct of the pituitary gland. And this happens because of ischemia or because of a hemorrhage as well, right? So this is going to be a large pituitary tumor with a hemorrhage. We're seeing that difference there. All right? Remember that. So the answer was a autoimmune adrenalitis. Definitely. It'll make sense. So what we find on labs, so let's do some kind of arrows situation here. If we checked cortisol, the morning cortisol, let's say we're checking morning cortisol, and we're checking ACTH levels. This is what they typically do. And then we give an analog of ACTH in order to see if there's any activity, right? Does that make sense? You're kind of doing that combination there. You're giving all these things. So let me see. We are basically, let me put the chat right here just in case anybody writes, checking the cortisol and the ACTH. How should the cortisol be in a patient like this? The morning cortisol. Low, yes. Good. How should the ACTH be in a patient like this? High, yes. Evidence of that is the hyperpigmentation. And when we check, we give the colsyntropin test. We basically inject something called colsyntropin to stimulate the cortisol and the ACTH level. What would be the reaction here? Would we start to see more cortisol after we give ACTH? So we give ACTH, and then we expect to see either a decrease or well, not a decrease, well, either an increase or it stays the same. If we give this analog, this colsyntropin, we call it, to stimulate the supraadrenal gland, if there is a true insufficiency, it should stay the same. It should be basically low. Yes, good. And we're talking low here. We're talking less than 5. Just giving you some values here. Should be less than 5. So it's going to prove to you to have a low cortisol level. All right. And I'll tell you, if, for example, we give this, let's say, this colsyntropin. Let's say you give colsyntropin at a higher level. Let's say you give a whole bunch of this colsyntropin trying to get some kind of stimulus, right? You basically try to check this out. You give ACTH stimulation test, and you're trying to see what happens in this sense. How should the levels of ACTH be? How should the levels, should it decrease or increase? That's my question to you. It would have to go lower, the ACTH now. Yeah, that's what would happen. You are right. If we give a hyperstimulation of colsyntropin, ACTH will then have to decrease. Okay? Understand that. We're going to see more of that in Cushing's as well. We're going to see that if you give for example, when we do endocrine, we'll see that hypothalamic, pituitary, and let's say adrenal axis. If I give the pituitary hormone, which is ACTH, let's say I give an analog, this ACTH, I will send a negative feedback that will basically lower the levels of ACTH. Does that make sense? Good. Okay, yes, I'll repeat definitely. So if, for example, let's say ACTH is increased, you're making a whole bunch of ACTH in this sense, right? And we're thinking, okay, ACTH at this point is very high because it's trying to stimulate the adrenal gland. This is from the pituitary. This is the, so we have, since the adrenal gland is not putting out cortisol, cortisol is low, cortisol is less than 5, then you have high incentive to stimulate these type of hormones, CRH and ACTH. But if I give ACTH to a patient at a high level, I would basically turn off the incentive to make more ACTH. So as a response to my hyperstimulus of ACTH, I will inhibit. Good. Yeah, that makes sense. Good, and we'll see that in the mechanism of GnRH. There's a whole analog, the leuprolide. It can be used differently. It can be used in order to, it can be used in a pulsatile way, where you are stimulating it. You're feeding this cycle. This whole hypothalamic pituitary cycle is being fed, where you're stimulating it little by little, making sure that it makes FSH, LH, FSH, LH. Now, if you give a whole bunch of it, like we mentioned, I said you have to give a large amount. Yeah, for infertility, you can mimic, you can give pulsatile GnRH successively, making the body put out more FSH and LH. But if I go and I inject a whole bunch of that leuprolide, which is an analog for GnRH, I'm going to shut down, I'm going to send that inhibitory stimulus. And that's what we're talking about right now, the inhibitory stimulus. So you'll see, we'll talk about that when we talk about pregnancy, when we talk about menstrual cycle and the drugs that can be given to induce ovulation, right? These are drugs that are used for infertility because you do need a proper amount of FSH to have rupture of the follicles in the ovary. So things like leuprolide are drugs you can use. And then they talk about chemical castration. Like, what is that? It sounds so bad, chemical castration. Well, that's what it is. It's basically leuprolide at high level. You give a whole bunch of it, and GnRH is off. GnRH is off, LH is off, FSH is off. There'll be lack of spermatogenesis, lack of testosterone. So that's leuprolide. We'll talk all about that when we get there. That's more of that you can see a male and female has usage in both scenarios. Okay, that's good. So just remember that the initial evaluation for a patient who we suspect to have an issue with their adrenals, let's say that they're insufficient, Addison's disease. If that's the case, then yes, this makes perfect sense. It will make sense to me that I would have to check the levels first of the morning cortisol and the plasma ACTH. And then I can give some ACTH in order to see the response that I get. So if I give the ACTH and I'm seeing that cortisol is not really responding to it, then there's an insufficiency. Then I can get my diagnosis. My diagnosis is made clearly. My diagnosis would be primary adrenal insufficiency, without a doubt. All right? That's how we can do it. That's how we diagnose that. Hopefully that makes sense. Right? Everybody, that makes sense. Yes. And yeah, that's perfect. That's good. So, okay, let's move on to the next question. Arrows. Oh, yes. Yeah, I love arrows. Arrows make everything so much easier. They really do, because you might not even know the full answer. And if you just know a couple of them, then you could rule things out and do it like this. So who wants to go tackle the next one? Let's go. Anybody. Let's get it.
I can do it.
All right. Perfect. Dr. Carey.
Here goes nothing. Okay. Okay, so further evaluations is most likely to show which of the above sets of findings. So we have a 4-year-old boy that's brought to the pediatrician's office for evaluation of worsening behavior over the last 4 months. His parents asked about a method to help him control his behavior. He recently started preschool and has been involved in a number of incidents of disobedience, which include hitting his schoolmates or on multiple occasions. His mother is also concerned because her son has begun to develop pubic hair. He has no medical or surgical history and is not taking any medications. Temperature is normal, pulse is normal, respiration is normal, blood pressure is not obtained due to the patient's agitation. His weight is 40 percentile, and height is above the 99th percentile of his age. Okay, he appears very tall for his age and easily frustrated, striking the door with his fists frequently during the visit. Okay, physical examination shows terminal hair growth in the pubic and axillary regions. Areas of hyperpigmentation are seen on the buccal mucosa. Okay, so after extensive lab testing, a diagnosis of 11 beta hydroxylase deficiency is made. Okay, so I was thinking about, before I even read that, I was thinking about, oh my God, precocious puberty.
Yeah, that is huge here. Definitely precocious puberty is being seen by a 4-year-old who's having pubic hair. That's pubarchy.
Yes.
Definitely. This is one of the features that this patient has. Definitely.
Okay. So since he has an 11 hydroxylase deficiency, right? So it's going to have virilization and hypertension. So I'm going to rule out B and A, because if you have hypertension, it's not going to be low, so it's going to be high. Then aldosterone is going to be high. Cortisol, okay, so cortisol and androstenedione. But okay, the only one giving me their aldosterone high is E. But I thought in 11 hydroxylase deficiency. So when you have 11 hydroxylase deficiency, you're not making anything else. You're not making the cholesterol, you're not making the androstenedione, and you're not making the aldosterone. Is that what it is? Or you're still making aldosterone?
Let's take a look at it. Because what ends up happening, what is kind of tricky about this, is that you can make an excess of weak mineral corticals. And that's what gets tricky with whole CAH, because you don't need to have aldosterone to have the aldosterone function, to have that. Yeah, that's
usually the androstenedione is going to be it could be increased because of the precocious puberty.
Okay, I'll show you right now exactly why this should 100% go into place. One thing that we see here is that this 11 hydroxylase deficiency, let's say there is no furthering of this pathway.
Exactly. So that's what I was saying. So there's not going to be aldosterone or cortisol or testosterone done. So that's basically.
Well, this is the thing. Everything likes to shift either. So there's this rule, let's say, where if you have a lot of precursor, it tries to go to the next pathway that's available. And here you're seeing that this hydroxyprogesterone can be shunted to the right to become an androgen.
Androstenedione. Okay.
Yeah, it can become, is the androgen factory, right? It can become one of these.
So basically the aldosterone, the cortisol is going to be low, and then just the androstenedione and the high blood pressure.
The androstenedione will have to be high. Now, why does this patient have high blood pressure if aldosterone is not there anymore? Why is there super high blood pressure if aldosterone and cortisol is not there? What is happening in that sense? I'll explain.
Okay.
In these kind of disorders, you're going to see something that becomes positive. And it's very interesting because this 11 hydroxylase deficiency is going to have these two high.
Yeah, the weak mineralocorticoid.
Now, this is the thing. The 11 oxycortisol, we said yesterday, you're going to see that this one is not biologically active.
Yes, you mentioned that yesterday.
Yeah, this one here, it doesn't really do anything. It's not really doing much, but it will be high as a marker. Like if they're asking you for like a marker, it will be high. This one here, it's a very, very weak aldosterone. It's a weak aldosterone. So you need to, in order to have this activity of 11-deoxycorticosterone, you need so much of it in order to give a patient hypertension. And that's what he has. Since he's having this enzyme cannot further catalyze its reaction to something else, it starts to accumulate so much, so much 11-deoxycorticosterone that this 11-deoxycorticosterone, although normally wouldn't really do much, but it's so increased that now it's causing this aldosterone effect. It's causing an increase in BP. It's causing an increase basically in the reabsorption of sodium, and sodium comes in with water. And this happens, remember, in the ENaC channel. So that's why this patient will basically, that's why the patient will have like a hypertension in the deficiency of 11-hydroxylase because of this one in particular. Their stress result is not that good. So what does that mean? When they're undergoing fasting, let's say, they can have complications. They can have a lot of issues. Why do I say this? I say this because you'll see that this one here, this corticosterone, let me give it a nice little color. This one reacts a lot like cortisol. So I'm going to write the names just to be clear of the fake, the mimickers, the wannabes, the ones that basically when they're high, yeah, they're the ones that are going to act like it. I'm going to say it right here. It's corticosterone. When this is high, this will act like cortisol. Cortisol. And when is this high? This is going to be high in a deficiency of 17 hydroxylase, when it can't go towards the right, where it's just isolated here. There you have an increase of corticosterone. So here, this will act like cortisol. So they do have a really good response to stress. If they're fasting, they wouldn't pass out, and they're able to respond with the catabolic activity of cortisol. So they're good in that sense. Now let me write the disease right next to it as well to not confuse anybody. This is going to be the 17 hydroxylase deficiency. Hydroxylase deficiency. That's the one that will be increased and it will act like cortisol. Now, we're talking about 11 hydroxylase. And in 11 hydroxylase, there's two of them that will be increased. We said one of them is going to be the active one. So let me put the active one first because that one is more important. The active one, of course, it has a weird long name. It's 11 deoxycorticosterone. So let me put it like this. 11 deoxycorticosterone. That's the one that will act like aldosterone.
Okay.
Mimics aldosterone. And then the other one that's increased is the one of less importance. That's the 11-deoxycortisol. Deoxycortisol. It's not enough for this to be biologically active. So I'm just going to put it like this. But that one is increased though. These are the two that are increased. Okay. So now we know who is responsible for confusing the crap out of everybody. These two things, basically, these two culprits. These are the ones that are giving you aldosterone effect without having aldosterone.
Got it.
And this one's giving you cortisol effect without having cortisol. So keep that in mind. This is what you would have to know when it comes to distinguishing all of this. So now let's look back at the question now that we got that one down. Let's see.
Got it. So then aldosterone is going to be low, cortisol is going to be low, and then androstenedione is going to be high. So it will be C.
Yes. Perfect. Good job. Good job. That was good. Definitely. And it makes sense, right?
Yes,
that one,
it did.
Yeah, that one makes
Now
sense.
it did.
Yeah, that's a good one. That's a good one. These These questions, I'm telling you, practice them correctly and they will become free points. And if anybody had a problem with them before and you were able to now flip them to get them right 9 out of 10 times, then that will reflect on the score. The score should go higher if you're able to do this with a couple of subjects that you consistently get wrong. You're able to now flip it to where now you're getting it right 9 out of 10 times. Automatically, your score has to go up. So that's how you get those extra small points to increase on an MBME. So this one here, definitely, I feel like if we do any questions on CAH, everyone will understand. It's not too crazy, right? Good, good, good. Thank you, thank you, thank you. So yeah, so one thing that we did see, something that we did see is the hyperpigmentation again. Hyperpigmentation kind of, ¿cómo sabía que? Okay. Yeah, so.
Doc,
Yes.
somebody named Jessie, she said she didn't get the email either in the chat, in the
All right.
WhatsApp chat.
Can you do me a favor and send her the link?
Yes.
I think I sent it to her recently, but send it to her again if anything. Yeah.
No problem.
She can join. Definitely. All right. So let's see. In this case, how did I know that the blood pressure was high? 11 hydroxylase deficiency. I'll tell you why. Once they gave me the diagnosis, once they mentioned the diagnosis, I have to remember the blood pressure will be high because in these type of patients with 11 hydroxylase deficiency, you are accumulating this deoxycorticosterone. They were nice enough to give us the diagnosis. That's how come I knew that the blood pressure was high, because they were nice enough to actually tell us what was wrong. They told us, hey, this is the problem. So just in case people don't remember, I'm going to show you one thing, the box. Let's go look at this box really fast. The idea, wherever there's a 1, it equals an arrow going up. Okay? So BP and also sex hormones. So take a look at this and let's understand this. 11 hydroxylase. You see how it has a 1? 1 equals an arrow up. So the blood pressure is going to be high on 11 hydroxylase. The sex hormones will be high on 11 hydroxylase. Now 17, there is no 1 here. So BP will be high on 17 hydroxylase deficiency, but the sex hormones will be lacking. So now let me explain something about the sex hormones. If you lack sex hormones, who benefits from this? Females. Females benefit from this. Females will benefit. When they're born, their genitalia wouldn't have all this type of abnormality, right? They wouldn't have too much, it basically wouldn't have virilization, none of that. Now, a male has issues. So who gets, let's say, screwed over here? Males. Males are in a bad situation here. Because now they cannot basically develop their external genitalia properly. Okay? They cannot develop external genitalia properly. That becomes a huge problem. Now let's look at 21 hydroxylase. On 21, you have a 2 here, so this blood pressure will not be high. But you have a 1 here, so sex hormones will be high. Androgen will be high. Now, who gets screwed here? Males are good. Males don't have a problem. Males are happy here. Male here will have his genitalia looking normal. The only thing that he will have is precocious puberty. He'll have axillary hair, right? He'll get this type of problem. Now, the ones who are screwed over here, the ones that are suffering the consequences of high levels of androgens will be the female. She would have virilization. She would have ambiguous genitalia, which is very bad. So settle that, get that straight, understand what's going on there. So whenever there's higher levels of androgen, the male wins. The male is not having these kind of issues. He will have some kind of precocious puberty, but Yeah, the female will have ambiguous genitalia. And here, 17, hydroxylase deficiency, females are saved. Males are going to have a problem here. Okay, good, good, good. We understand the box and we understand the difference between those types of hormones. That's perfect, perfect. All right, let's continue. Let's continue. All right. Let's take a look at this one. Who wants to do this question? Let's see. Let's see. Who's next? Who is next? Anybody, anybody. I know everybody's reading it thinking, hey, is it hard? Is it easy? If it's easy, I'll take it. If it's hard, I'll leave it to someone else. If that's the okay, hold
If
on.
someone wants to do it, I can do it. Can I do
Oh,
it again?
okay. Yes, of course, of course.
Okay.
Oh,
Okay.
It was okay.
If someone wants to volunteer, you can go ahead, Mona. I guess it's you, Mona,
oh,
right?
okay, okay. Let me see. Okay, so we'll do this. Mona, you get the next one, and you get this one, and then Mona gets the next one. And you did speak up first, so you get this one, and then we'll look at the next one.
Okay,
All
perfect.
right.
So, which of the following is the most likely diagnosis? A 30-year-old woman comes to her primary care physician because of increased urination and thirst over the past 2 months. She has also recently gained 3.2 kilograms and feels that she has gained most of her weight in her abdomen. She also reports frustration with acne and facial hair, neither of which she has dealt with in the past. She has a history of asthma, which is poorly controlled with inhaled budesonide, formoterol, and albuterol, and has had multiple asthma exacerbations in the last year, requiring hospitalization. She also has a history of migraines, which are well controlled with topiramate. She's a monogamous relationship and doesn't smoke or drink alcohol. Temperature is 37, pulse is 90, respirations are 14, blood pressure is 143, which is on the higher side. She is 160 centimeters tall and weighs 77.3 kilograms. Body mass index is 30, which is on the higher side as well. She appears obese and has a round, flushed face. The physical examination shows a dorsocervical fat pad with scattered ecchymosis on her extremities. There is acne along the jawline and pores, dark hair on the chin, and then we have bunch of laboratory studies. So her early morning cortisol level is 5. Uh, Normal is supposed to be less than 1.3. Oh, so she basically is administered with steroids the previous night. So which is on the higher side. So 24-hour urinary cortisol is 200, which is also on the higher side. ACTH level is 5.2, which is low. Fasting blood glucose level is 328 on the higher side, and then we have a CT scan that shows no abnormality. Okay, it's a very straight up question, and it's a Cushing's disease.
Okay, so you're saying the answer is
Um, So let me see, because the thing is, her ACTH level is low, even
yes.
after the even after administration of the dexamethasone, and her cortisol level is on the higher side, which shows that after giving the steroids, her cortisol levels were not suppressed, and her ACTH level is on the lower side. So
So yes, what would you do here? If you're pushing this question here, they're kind of throwing you off because they're giving you some kind of weird features here.
yeah, it does
So
look like that it's a Cushing syndrome, but now I need to figure out whether it's from the adrenal glands, like a Cushing syndrome or a Cushing's disease.
okay, so what are the different types of let's say reasons that a patient will have an increase in cortisol? So let's try to name four of them because it will have to
Okay.
be one of those basically.
Okay.
Let's
So we can have like a high cortisol levels if it's if it's the adrenal adenoma coming from the adrenal glands,
All right, what layer
and
of the adrenal gland?
so from the zona fasciculata
Yes, if you have some kind of, let's say, tumor coming from
tumor.
here, that's a primary.
Yes, yes,
So yeah, we can say primary adrenal gland tumor. Okay.
yes. And then in the pituitary, if we have a tumor that's releasing excess ACTH,
Okay,
then we
so
can have,
yes, pituitary as well, right?
yes,
ACTH.
yeah. Or if we have a ACTH coming from some tumor, such as in the what is it called? The squamous cell carcinoma.
Okay,
Like
that's a good one.
yeah, coming from another tumor. Okay.
The lung, basically, let's say, right? And what do we call that? We call that ectopic.
Yes,
We call
ectopic.
this ectopic Cushing, right? Ectopic.
Yes. And then we can have drug induced where the patient is taking excess of steroids.
Yes, there can be, uh, this is like, you'll say this is exogenous. That's the difference. That's a different name that they use, exogenous. Or they
Yes.
like to also call this iatrogenic as well, but exogenous as well. So yeah, we're getting a whole bunch of different causes. That's great. What else? I think that's about it, right? There's one more though.
Is it drug induced will be the same as exogenous.
Yeah, drug
So
induced is the same in that sense. There is a tertiary type. Let's say it's more rare, of course. It's not something that it's typically seen, but you're going to see that there is this type that has to do with CRH. You have an increase, let's say, in the hypothalamic, and you're increasing a whole bunch of CRH. Let's say. Right? That's a tertiary type.
okay, perfect.
All right. So there we're having all these different types, all these different types of issues, right? And they gave you all the features. If you look at the question, they gave you the moon face, they mentioned muscle wasting, and they basically mentioned everything there in that sense.
Yeah, and now I'm thinking, so if she is asthmatic and she's taking steroids, so it might be iatrogenic Cushing syndrome.
Yes. If she's asthmatic, if she's asthmatic, you remember that you have a
Yeah.
stepwise type of treatment for these patients.
Yes.
Remember, yeah, typical treatment for these patients are going to be based on, yeah, so the answer is B, 100%. That was a good one. And typical treatment of asthma patients are based on a particular symptom that we are very aware of is that they wake up in the nighttime with the exacerbation. So if the
Yes.
exacerbation is waking them up, then we start to look at how serious the condition can be. We start to add medications according to how many days, how is it monthly, is it weekly, how often do they get woken up in the nighttime because of exacerbation of asthma. Whenever that happens, we start to add medications. So it all starts off with albuterol. Remember, our albuterol is just a beta 2 agonist, right?
Yes.
Remember, I don't know if you were with me from the very beginning when we were talking about the battle of the receptors. We said beta 2 goes up against M3. We said agonist of beta 2 causes bronchodilation, and agonist of M3 causes bronchoconstriction. So, definitely, when you're looking at, let's say, the treatment of asthma, remember that asthma as well is provoked by leukotrienes. Leukotrienes causes bronchoconstriction. And part of the leukotriene pathway gets activated by arachidonic acid. Remember, we mentioned that the job of cortisol, the job of steroids, is to block these enzymes that like phospholipase A2. So it influences less degree of leukotrienes. That way, the patient will have less bronchoconstriction. But the issue is if you give a prolonged treatment with let's say with steroids, several things can happen. Several complications can happen if we're prolonging the treatment of steroids. One thing you should think of, remember that NFK beta reaction goes on in the bone because the activity, all osteoclast and osteoblast, have to do with monocytes, have to do with, let's say, the bone macrophages. So if you're inhibiting the activity of bone macrophages, you'll have an issue with the bone. You can easily get fractures. So that can happen. That's the drug-induced type of fracture. And I'm remembering an artery that they love to mention. They love to mention one little artery there that has a problem here called the medial circumflex artery. Circumflex. And that is an artery that gives irrigation to the proximal head of the femur, and patients who are taking steroids are prone to get a fracture of this area. And they'll ask you, for example, what vessel is involved here? Medium circumflex. That used to be a super high yield point, seen everywhere on UWorld before. But steroids can cause, let's say, prolonged use of steroids can cause fracture. That's for the prolonged use. In this question, it looks like they're talking more about the increased dosage instead of the prolonged. In an increase in dosage, what can we get? What we can get is what we see here, the effects of Cushing, the Cushing effect. Increased duration, you'll have fractures, and then you can also get something else, because once you discontinue the steroids, once you take the patient off of the steroids, this adrenal gland can have insufficiency. Does that make sense? They were on steroids for so long that now the hypothalamic pituitary adrenal axis is weakened. It's not functioning correctly.
And I guess it's called as secondary adrenal insufficiency, right?
Yes, yes. Definitely. That's basically what you see in this sense. Now, basically Cushing, this let's say this type of patient who's having this kind of issue, we have a whole way of diagnosing Cushing, and we'll get into Cushing disease. That should be the next topic, I think, about it, because it does have a lot of significance. We can talk about the cancers, we can talk about so much. I think that's more of a class, because if we get into it and the next step in management and how we look at it, I have a class just based on that with a nice little mnemonic that wraps everything up. Because I remember the word Cushing. This is how the mnemonic goes. I know I'm a little excited here. I'm just going to show you for the next class. You'll see, and it'll be a lecture class instead of a question class. But I remember cortisol. You give that cortisol. You take the urine cortisol. So then I remember steroids. You actually give them steroids. There's 3 different things that you can do. The salivary cortisol, the urine cortisol, and I remember you actually give the steroid, the dexamethasone suppression test. You give them this to see how they respond. Then H was for the other hormone, which was ACTH. So this is all like a mnemonic into my head, and then I can get the diagnosis immediately. And I'll show you guys this on the next class. This is just me without the notes, just going off the top of my head. But there was a way that you systematically approach this. So just in case they ask you what's the next step in management, you can get the answer right there. This is more like a step 2 kind of approach there, where you can just see and be like, okay, well, they're up to this part. Well, then I have to do this. Like we're checking ACTH level. Let's say you're going to see if it's suppressed or not. If it's suppressed, there's 3 different diagnoses you can think of. It could be an adrenal adenoma, for example. Adrenal adenoma. Because the adenoma itself is sending negative feedback to the pituitary saying, hey, we have enough. So the pituitary will not put out more ACTH, right? So if you've seen that ACTH level suppressed, that makes sense. What else? Exogenous, what we just saw right now, the exogenous type. Exogenous type. That's also going to have a decrease in ACTH levels. It should be suppressed when you look for it. It should be suppressed. What else in this sense? Yeah, malignancy, adenoma. Same thing goes for, let's say, yeah. Basically, these are the 2 major things that you should think of. whenever you're thinking of a suppressed ACTH, the combination of low ACTH, but a high cortisol kind of doesn't make sense there. So two things that should come into your mind is that primary and exogenous. Okay, that way we don't have to theorize and let's see. The exogenous when given the high dose index. Okay, I'll tell you. The idea behind that is this: is that if I have, let's say, so what's the idea? I'll tell you the idea. Why are we giving high dose and low dose? What's going on? If I give a low dose and then I see that cortisol is increasing, that can just be a problem with the hypothalamic pituitary axis. So if I give, let's say I have a high level of cortisol, and I'm able to give some kind of dose and it doesn't suppress the level of ACTH. ACTH remains the same and cortisol reacts, let's say. Cortisol like slightly increases. I can say, okay, well, I'm seeing that this level of cortisol was not enough to shut down the pituitary. Remember what we said. Whenever we give a super high level of cortisol, let's say now we give a really, really high level, then you're able to override and shut off the pituitary. So that's the difference of like a low dose dexamethasone test with a high dose. High dose, you're giving it to make sure that you can turn it off, to make sure that it's not something in the pituitary. But yeah, we'll talk more about that because we can go into that and spend a whole nother hour. So let's keep going with these questions. Let's get at least, I want to get at least a couple of good questions. So let's see. So far, yeah, we did mention a couple things. Let me see if you guys can understand what we do for next step in management for these type of patients. Let's see. Who wants to step up for the next one? Mona, if you can, if you're available, that would be nice. I would appreciate it. Let's go.
Okay. All right. So which of the following is the most appropriate next step in management of this patient? So a 35-year-old man comes to the office after a year of weakness, fatigue, and weight loss. He has experienced reduced appetite and intermittent diarrhea. Patient has no improvement after several sessions with a clinical psychologist who suggested evaluation for a psychological cause of his symptoms. A physiological cause, not a psychological, a physiological cause of his symptoms. His medical history is unremarkable. He takes no regularly scheduled medications. Patient does not use tobacco, alcohol, or illicit drugs. Family history is notable for hypothyroidism in his sister. His temperature is 99 degrees Fahrenheit. His blood pressure is 106/66. And his pulse is 94. Respirations are 14. On physical exam, the patient does not appear to be in acute distress. His neck shows no thyromegaly or lymphadenopathy. Cardiopulmonary exam is normal. The abdomen is soft with normal bowel sounds, no organomegaly. Motor strength and deep tendon reflexes are normal and symmetric, and then the labs are as follows. So, all right. His cortisol is okay. In the morning. Sorry, I jumped. I didn't go straight down the line.
It's okay. I like also when I do questions, I'm jumping all the time because if something is out of the normal, I want to highlight it immediately just so it could like kind of smack me in the face and I could just see it like, oh, okay, this is what the question is setting me up for. So yeah, some things did jump at me as well. So yeah, it's okay to jump wherever.
The other thing is his potassium, I think, is high, and his sodium is maybe low. Like
Yeah,
maybe just
for sodium, remember it was 135 to 145.
yeah.
So here, definitely you have a low sodium level.
And then potassium, is that also high?
Yeah, potassium here is high. I remember 3.5 to 5. That's what my memory tells me. So yeah, this one is also high.
Okay,
That's
so
increased.
I feel like he's having something with his aldosterone. Let me think. And his blood pressure is low. Well, it's on the lower side. And he's having weight loss, fatigue, and he has experienced reduced appetite, and intermittent diarrhea. So yeah, I'm thinking he's having an issue with his aldosterone.
Okay. That makes sense. Remember, when we think of aldosterone being low, definitely we'll think of a higher level of potassium, lower level of sodium, and also a lower level of BP. That's the triad. It's not even a triad. I call it a triad. It's the salt wasting. That's the whole idea of salt. Not having your aldosterone functioning will cause this. So that's good. But I'm going to mention another little feature here. A feature that kind of tells me that there's more issues as well. So,
Okay.
Well, check this out. One thing that they mentioned here was weight loss and fatigue and weakness. So I will mention something right now, and let's make sense of this 100%. And whenever we go to other subjects, we'll see this again, and I'll repeat it and we'll preach it. It's the whole idea of, go ahead, weakness, and weight loss. Remember one thing, that cortisol, let's say cortisol, it has a lot of contribution when it comes to, let's say, weakness. It has a lot of contribution as well when it comes to the metabolic functioning. Metabolic functioning. You'll also see this as well. What else? You'll see that when patients have weakness. So yeah, let me just extrapolate one more thing. Let me just tell you one thing that is important as well. I should have actually mentioned this with glucocorticoids. So let's sidestep here. One thing that's super important is when you see, so this is not too related to the question, but I'm just going to mention one thing. When you see a high level of steroids, you can tend to see something called muscle weakness, which is going to be looked upon as proximal muscle weakness. And the way that they put this in questions, it's going to have a detail. They're going to want to mention that the patient has a problem standing up because it's proximal muscle, like your thighs, or he has a problem combing his hair, or he has a problem putting something on a higher shelf. These are proximal muscle problems. Usually you'll see this in myositis, a lot of myositis. So yeah, I know this is like not completely 100% related, but I have to mention because we didn't mention it when we talked about higher levels of steroids. Patients who are using a lot of steroids can tend to have myositis. And the proximal muscle weakness is huge. It is something very important. So I'm going to show you guys. I'm going to put this on the chat. I have here some older notes of myositis that I've did a long time ago, but it was a differential diagnosis. It definitely helps for differential, and you guys can look this over in your free time. When you have high levels of glucocorticoid, you're going to see that these patients will have this kind of myopathy with an increase in weakness. That's going to be huge. And it tends to have normal ESR, normal CK. Normal ESR, normal CK. Why? Well, it should make sense. If you're not activating inflammatory factors because of glucocorticoid, glucocorticoid is blocking pro-inflammatory proteins. So ESR is not really that much increased. because you're not having a whole bunch of proteins in circulation that have to do with inflammation. And CK is what leaks out of the cell when you have myositis. So that should also be normal. Now, I'm going to tell you, these are not too reliable, ESR and CK. So I'm going to put this on the chat so you guys can use this for your benefit whenever you see a patient. And I'll show you whenever we do questions on this. The main symptom will be proximal muscle weakness, issues going up the stairs, issues standing up, issues putting something on a shelf, combing their hair. That's the type of clue that they like to give you because this is particularly the proximal muscles, like the muscles located humerus, femur, like around that area, right? Thighs and triceps and arms. But okay, don't want to confuse you, but I did see that did stand out. Weakness, fatigue, weight loss. So, but through it all, though, if you look at cortisol is looking normal. Cortisol is looking normal. So far, you're going good. You said something about aldosterone, and that makes sense. If aldosterone is low, then potassium definitely will be increased.
Mhm.
If aldosterone is low, the blood pressure wouldn't look too good there. And it is on the lower level, yes. Remember, hemodynamically unstable has to be less than 90. We learned that on cardio when we're trying to manage patients who are having arrhythmias. Remember, hemodynamically unstable is less than 90. So keep that one in mind. But so he is hemodynamically stable. And yeah, he looks like, so his neck shows no thyromegaly, so there's no thyroid problem. Okay, so what is your diagnosis here for this patient?
Yeah, so decreased aldosterone, hypoaldosterone.
Okay, it could be a decrease in aldosterone. So
The thing that's throwing me off is the weight loss because I think they would retain, like they would get edema, right? That's what's kind of confusing me.
well, no, I'll tell you why.
Okay.
You're probably thinking because when you have an increase in aldosterone, that's when you're reabsorbing a whole bunch of sodium.
Yeah.
That's when you'll have a volume overload.
Okay.
When you have an increased level of aldosterone, remember the mechanism of aldosterone. Aldosterone is going to do three major things. Aldosterone, when it's high, let's see, is going to be able to reabsorb sodium. So ENaC channels are responsible for that. So you're going to have a higher level of sodium. Wherever sodium goes, H2O follows because of its solute effect. Okay, then you have the excretion of potassium, and that comes from ROMK activation. That's going to decrease your potassium. And then, of course, you'll have your, well, increase in aldosterone, your BP. And the BP is basically because of the volume here.
So they would have increased.
Yes.
Okay, so it's low aldosterone that he has.
Yes, that makes a lot more sense, right?
Yeah.
Okay. Okay, Carrie, I see you. That sounds good, right? It sounds like, yeah, he has low aldosterone. So what could that be? We really don't know in this sense. It's kind of like, okay, well, this can be low aldosterone. So the good thing about this question is that they're really asking you what's the next step in management. So what do we do? I'm going to show you the answer choices and you can pick one. What do we do if we suspect that the patient has a decrease in aldosterone, an adrenal insufficiency? Now, cortisol, you're seeing it's not like, let's say, out of the normal range, but it is on the lower spectrum here. It's on the lower end. So let me show you this. What do we do here? What would be the best answer here?
Oh, okay.
Yeah, let me situate this nicely. You can see the question as well. What would be a good approach here?
So you, let me think. Okay, it's not a C. You don't need to do anything with the insulin. You don't need to check his, let me think, ACTH. No, you don't need to do B.
So
Don't, I
So-
want to, okay, oh, sorry, go
yeah,
ahead.
yeah, no. So go ahead. Tell me which one is more appealing to you, and then we'll talk about it. Go ahead.
I want to say, wait, let me back up. I'm overthinking this. Okay, wait, let me back up. You don't need to do E. You, for management, not diagnosis, right? This is management.
Well, no, they just want to know which of the following is the most appropriate next step in management of this patient. So they're very slick with their words here. They're not trying to tell you, they're telling you what's the next step. Like, what do you do to a patient like this?
Okay,
They're not asking you how do you treat.
okay.
They're just
So
saying what's the
first-
next step.
So first you would see if there's something going on with the adrenals, right? To like diagnose it.
Okay, I like that answer because if you look at everything else, for example, if you're taking a look at everything else, we know that aldosterone is involved. We can tell because of what we mentioned. We mentioned the low sodium, the high potassium, and the kind of shady BP there. It's kind of close. So we said, okay, well, we're suspicious of aldosterone. Cortisol, not that much, right? Because it kind of technically fell into the good range, but it did have weakness, fatigue, and weight loss. That's cortisol problems, but nevertheless, 8 a.m. cortisol is normal. So yes, we are suspicious on aldosterone. So a question like this, a good approach to have, let's say we don't know the answer. And yeah, it's good to be in situations where you don't know the answer and you just have to fight your way out because you'll find yourself in this situation sometimes. So if you're comfortable in this situation, then you won't panic, you won't go thinking deeper thoughts and somewhere else. So the best thing to do is think to yourself, I'm suspicious of aldosterone. I know enough to think that this might have something to do with aldosterone. And having that confidence in yourself is a big step because I'll tell you what happens. Many people, let's say students taking an exam, they might be in a phase where they're having low scores. So they learn something pretty well. And since they have reinforced into their mind that their score is low and that when they take tests, they usually get the wrong answer, they have come with the idea, reading the question, they can think, okay, well, this looks like aldosterone. But then they're thinking, I mean, what are the odds that it's aldosterone? I get so many wrong. Last time I got a 50 and it's 1 out of 2 that it's aldosterone. And that's a problem because if you can naturally just have confidence in what you know and say, this might be aldosterone until I get something that proves to me that it's not, then I should think that I am going to pick an answer that has to do with aldosterone. So that kind of reflects. This is why people would have different scores when they're feeling differently. Like if you're feeling great about yourself, you're happy and positive, you can probably get a slightly higher score because you didn't change your answer. Your initial thought was right and you went with it versus someone who is doubting themselves. And if we think that it's aldosterone, we can say, okay, well, what here has to do with aldosterone? Here they're checking the 24-hour urine-free cortisol. That has nothing to do with that. That is more of a checking for Cushing or checking to see if cortisol levels are normal. And we already did an 8 a.m. cortisol test. Why are we doing more cortisol exams, right? And you said it, when insulin-induced hypoglycemia test, like, why would we do this? This is like to see if there's sensitivity of insulin. And like, I mean, why would you do that? That's like a PCOS patient or something in that sense. And that has nothing to do with this. Intravenous hydrocortisol. Okay, that's again going with the angle of cortisol. Is going with that angle. It's like that doesn't sound too good, but let's not eliminate it because I mean that is a supraadrenal gland technically. Low dose overnight dexamethasone suppression test. These are the tests that are done for Cushing. This is not a Cushing problem. We already saw that cortisol is normal. Our suspicious is aldosterone.
Yeah.
So what stimulates aldosterone?
ACTH.
ACTH. So if ever we are suspicious, for anything that would have to do with primary adrenal insufficiency, the reason I tell you that ACTH is basically one of the best approach to this. Now, I'll be honest here. That is not the proper, let's say, next step in management. It isn't, because what is the proper next step in management? You want to make sure that you test your ACTH levels and your cortisol levels, right? You want to see how much you have. Then you give that cosine syntropin test, which is this one here. This is the cosyntropin test. Cosyntropin test. It's like, okay, well, first I would want to know the cortisol level. They did this level. That was okay. But why not check ACTH levels as well? You know, so if ACTH, like checking ACTH was on the choice, I would have picked that. You see what I mean?
Mm-hmm.
But they didn't put that. They're very slick in that sense. They're like, hey, we're not going to give you the pick the best answer on the list. So I would have to know if I suspect a patient of having some kind of primary adrenal insufficiency, and let's say they were being very shady in the way they were proposing this question. Instead of them going all out with the cortisol, they only gave me aldosterone issues, which is kind of bad of them. But to be fair, they did mention the major symptoms that are involved in decreasing cortisol. The major symptoms: fatigue, muscle weakness. Oh my God, this one here is the whole muscle weakness problem. That one is huge because, yeah, you can get this type of issues if you don't have cortisol. So definitely, let's say the BP issues with aldosterone, the increase in. If I feel like anything in the supraadrenal gland is not functioning properly, I should check cortisol levels, and I should check ACTH first. Then I do a cosyntropin, which is basically ACTH agonist. Cosyntropin test. And a cosyntropin test will definitely tell me if the situation is basically the supraadrenal gland that's damaged. And this is what it might be, because remember that this autoimmune issue that starts to attack the supraadrenal gland, it's something gradual. It's something that happens. It gets worse and worse as time goes by. So we're seeing the levels drop. You're seeing how cortisol is now at the lower end. Give this a couple months, maybe cortisol is now going to be low. So you're kind of diagnosing this disease before it reaches the lower spectrum of labs. So it makes sense to me that this might be some kind of adrenal autoimmune problem that's slowly chipping away at the supraadrenal gland. That makes sense to me, as opposed to something else, let's say, like Neisseria meningitis or TB or something of that sense. This kind of makes sense. But in order for me to confirm that type of bias, I would have to give ACTH and not get the results of an increase in cortisol. So what do I mean? All right. If I give the ACTH and I see that the cortisol is still low, it's not increasing, for example. Now I'm thinking the supraadrenal gland not functioning like it should at this level. If I gave this, if I checked the ACTH in the beginning and I saw that ACTH was originally high, that kind of supports the primary adrenal insufficiency. It kind of supports this. So yeah, you can use all these labs to try to get your diagnosis. It works a lot better this way. Definitely makes sense, right? Answer choices here will always help you, because you could easily rule out things. Sometimes they know in what situation you're in, so they can't put an answer that can be too similar. So they'll have to do something where all the other answer choices are just another hormone completely. Okay, so keep that in mind. And this here, I'm going to put this on the chat. This is a way to get your diagnosis just in case there's any issues with myopathy. And we can look at this down the line whenever we check out myositis and the differences, the issues here, the differential diagnosis. I'm putting this in the chat. And also, let me mention, so this tier here, this tier that we're doing right here is a question tier. This one is not really based, let's say, on class where we're sitting down giving lectures. This one here is based on trying to tackle questions. So we're trying to basically use what we got from the class and take everything that we know from the class and now use it to translate it to points. And I'm trying to show you techniques and approach when it comes to questions. Like, how do we approach a question? Anything, any kind of, let's say, clues or anything that we see, we can use this to try to answer questions. So let's see, somebody says a question. In secondary adrenal insufficiency, we'll see low levels of ACTH after administering cytotropin. So what you will see in secondary, when you are, let's say, the response that you'll get when you give colcentropin, yeah, you shouldn't. In secondary, no, you shouldn't. So secondary, you're mentioning secondary as a pituitary problem. It's okay. This is primary is going to be the supraadrenal. So secondary is the pituitary problem. Okay. Yes. Your question is, in secondary adrenal insufficiency, we'll see low levels of ACTH after administering colcentropin. Before administering it, you'll see low levels. After administering it, you'll see low levels. Right? Because ACTH will not be present. You have a problem putting out ACTH in that sense. Okay? Keep that in mind. So yeah, basically what I'm mentioning is that when it comes to this tier, this is an extra tier. This is a tier that I'm having on Patreon when it comes to doing questions. So if you like this tier, if you want to join, go on the Patreon and join this tier. I'm going to make 6 classes for now. It will be 2 classes for 3 weeks, meaning first week, 2 classes, second week, 2 classes, third week, 2 classes. And we'll use this as supplemental approach to the actual lecture classes. So far we have question classes. We have lecture classes. So if you're signed up to the lecture classes, you could also join up, sign on to this tier. This tier is also $25 per month, and you'll benefit from the recordings of all this. So all these sessions are going to be recorded, and I'm going to put them up on the website. I was editing the other video that I did before. It's going to probably take, by tomorrow it should all be ready. I'm going to stay up tonight and do that. So definitely thank you everybody for joining me tonight. We did some questions today, and yeah, we got a couple questions down. We'll flow a lot easier down the line in the future. Thank you everybody. I really wanted to thank everyone who participated. You sign in on Patreon basically. So on the Patreon, I opened up a new tier. You can upgrade the tier. So let me put the website right here, patreon.com/Dr. Batista USMLE. This is it right here. Oh, sorry. Yeah, let me copy this and put it again. So yes, this way you will benefit completely from the class and the actual practice. We'll put it all in practice. We'll put everything that we learn into practice, and I'll show you guys how to approach questions, little tricks that I have, little clues that basically get me to a diagnosis. And yeah, this is also going to include a lot of step 2 approach. So you're seeing, like today, we were talking a lot about next step in management. So definitely, I'm going to also approach this. Why not? As soon as we mention a diagnosis, we say how we get the diagnosis. We mentioned the differentials. A lot of talk about differentials as well, because a lot of questions will have one feature that will differentiate one answer from another. So we have to make that clear as well. And yeah, this is how we're going to do it. That way you can benefit the most you can from these classes. So definitely I look forward to making and giving a whole bunch of more classes, and who knows, even open up another tier where we're doing drills, and we'll see how much time I can dedicate to this project. But so far it's been my favorite project that I've ever worked on so far in my life, because it's like exciting. So definitely I'm going to create the next calendar as well for the next month. I'm going to be open to suggestions. So anyone who definitely is a member, I'm going to put a poll and vote on the poll. Let me know what subject you want the most. If you have any suggestions, you can write them in right now. I don't mind. Or send me them in direct message. Definitely, I'll use your suggestions as a way to make a class and a way to approach the most difficult types of subjects, the most confusing type of subjects. I want to simplify everything for everyone. That's the goal. That's the plan. Because there's other ways of looking at medicine. Endocrinology, definitely. Endocrinology is the next subject without a doubt. We're already slowly creeping into it, but we also have to mix in some repro, right? We have to go to the point of pregnancy and childbirth and teratogenics and all that type of issue. We have to also flirt with that a little. I don't know too much about, let's say, getting into oncology of it. That's something more that should study basically a lot of that on your own. You're just going to see a lot of features that differentiate stuff. Probably get into that in the future, but in order to keep a proper flow, we'll do reproductive, and then we'll jump into endocrine next. And yes, after endocrine, I'm open for more renal. We can repeat subjects, but hit them at different angles. We can always repeat cardio, all these other subjects, we can repeat them, but from different angles. There's things I never mentioned on renal. There's things I never mentioned on cardio, because we only were doing like 3 days, 4 days of this. I think the one that I did the most was renal. It was a neural. Wow. I went hours and hours giving class on neural. It was insane. But yes, thank you everybody for joining me. I appreciate it. Can we do more hour questions for Respo and Endo? That sounds actually really good. Yes, that sounds really, really good. I like that one. Yeah, let me screenshot that arrows. I should just have a class on arrows based on subjects. Like we should close off a session with just a bunch of arrow questions and explaining why on everything. I like the idea of arrows. So let me put this here. I'll put it here, that way I remember. Let me stop sharing. And yes, definitely. That sounds great. I like the idea. Someone said, can you send it on WhatsApp? So what should I send? Tell me and I'll send it right now. What should I send? The link? Let me see. Okay. Yeah. I'll send the Patreon link on WhatsApp group. Everybody can join. Yes, for the tier update. Definitely. I'll do that. So thank you, everyone. I appreciate everyone joining the class. I love it. Definitely gets me motivated to give even better class. And yeah, I'm newish on this, giving group class. I always give them one-on-one, but now I'm loving the group class. I started on March, April. Now we're finishing May. So far, this is growing. This is nice. I like it. So I'll catch you guys. Let's see. But we have a drill coming up on the calendar. And I'm going to redo the calendar as well, because we also have more question sessions. So if you guys join the question sessions, as soon as you join it, you'll see we're going to have more like next week. Starting like Monday, we'll have on Tuesday for sure. I know Monday is Memorial Day. Tuesday for sure, we'll have a questions session, and Wednesday. So those are the 2 next days where we would have more question sessions. So definitely sign up if you can, so you can you can participate in Tuesday and Wednesday. Okay. Thank you, everyone. Have a good night, and I'll see you guys down the line. Thank you. Good luck and good studies. Goodbye. Thank you. Thank you, Mona, for participating. Thank you. Thank you, everybody who participated, and everybody for joining. All right. Bye.